Our speaker is Ms. Linda Barnes, who's Chief Operating Officer and Chief Information Officer at Puget Sound Blood Center in Seattle, Washington. She will be speaking on quality, ensuring integrity from arm to arm.
Because blood transfusion carries full circle from the donor to the patient, and unless we look at the entirety of the process from arm to arm, I think that we miss opportunities to improve and make blood transfusion safer. The other thing that I would like to share, thank you, Megan, for that very kind introduction. I have worked in a variety of different settings in addition to working at the Puget Sound Blood Center, where we collect approximately 200,000 donors per year. We have a centralized transfusion service where we do the compatibility testing, the pre-transfusion testing for about 300,000 units per year. And we also have clinical services where we perform patient care, hemophilia treatment care, and a research institute that is important to the innovation within our organization. When we think about quality in blood transfusion, I really focus on the patient and who it is who is the ultimate customer of our services. And that is someone who is in need, who is calling out for a champion, for someone to look out for their care and for the care and treatment that they are receiving. So today, I plan to talk with you about quality champions. We have referenced this throughout the lectures over the past 2 days, the importance of having someone with responsibility, authority, and I thought it would be important to reflect on, well, what are the characteristics of a quality champion? And what does an arm-to-arm quality system look like? What are the elements of adequacy, availability, safety, efficacy? And what is it that should motivate us for improving our quality system? Further, along the lines of continuous improvement, how is it that we can reduce and prevent errors, implement evidence-based practices, collaborate in an interdisciplinary way? And lastly, what does high-impact leadership look like? When we think about blood transfusion from a general public point of view, I pulled some newspaper articles that are often what are called out to the public, to the individuals who are our blood donors. We often hear about situations where someone received a transfusion and was infected, in this case, HIV infected. Or patients might complain about infections, in this case, hepatitis C, related to blood transfusion. And there are oftentimes government inquiries related to, was best blood bank practice adhered to? And these inquiries are often advanced by advocacy groups who are looking out for protection in the future for other patients to prevent harm. What we don't hear about often are the other risks of transfusion, such as arm preparation technique, in this case, a situation where arm preparation is being performed with simply an alcohol swab, donor deferral histories, and the importance of maintaining donor deferral registries so that we can assure that individuals who should be prevented from donation are indeed declined in the future. We also heard about transfusion practice at the bedside and the importance of patient identification practices. In this case, a patient does not have an armband, and yet you can see he's receiving a transfusion. And lastly, compatibility testing, pre-transfusion testing, and ideally screening. In this case, you can see the compatibility testing is being performed on a simple ceramic tile, purportedly at the bedside, but in this case, it is actually in a room down the hall. These are pictures that I've collected from some of my experience working on international blood safety projects in countries like East Africa and Sub-Saharan Africa. None of these pictures are from those areas, but many countries struggle and are working diligently to improve their blood safety and their blood strengthening activities. But I do want to point out that you are not alone in this. And these are the types of things that often don't make the headlines and yet are equally as important as transfusion-transmitted disease testing in order to assure adequacy, both in the blood center and in the clinical practice setting. We heard earlier today about how blood transfusion is not new to us. Since the 1600s, transfusion has been studied, and there are 3 areas of transfusion and blood safety that have been identified. This was collected from the History of Blood Transfusion, a bulletin in the Medical Library Society from 1942, and they identified that blood, of course, is labile, perishable, and it clots, and that the donor might lead to adverse consequence in the patient. And lastly, there's always a risk to benefit ratio that needs to be considered when blood transfusion is warranted. So these are not new issues, and many countries have been working on this. My own country in the US also continues to work on how to improve blood safety, but one of the areas that is particularly important is that of the quality system, and how do we ensure that there is an intact record and safety from arm to arm. The WHO published this information from the year 2012, indicating that there has been improvement in blood collection and blood safety. And since 2004, there's been an increase of almost 25% in the number of units collected around the world. However, high-income countries contribute about half of the units collected, even though they constitute only about 18% of the world's population. Whereas in low-income countries, we've already heard about children who are oftentimes the recipients of blood transfusion, whereas in high-income countries, it's actually the opposite, where patients over the age of 65 account for most of the transfusions. And I think that this draws forth an important point that I know that we've discussed throughout the past 2 days about the importance of having evaluation at a local level, because certainly the considerations for a 65-year-old are much different than that of a child under the age of 5. The blood donation rate is different from low to high-income countries. In high-income countries, it's approximately 36.8 donations per 1,000 population, whereas in low-income countries, it's 3.9. And we heard information about low-income countries, including Sub-Saharan Africa, Uganda specifically, as well as Kenya, who struggle to achieve this goal. And that voluntary unpaid donors are the ideal. In fact, it's important that they be repeat donors. I'll cover that data later. And I'm pleased to hear that many countries in Sub-Saharan Africa have been able to achieve this, but others still are behind. WHO, in their strategic plan from 2008 to 2015, identified several factors that we should be looking at: national blood transfusion system, collection of low-risk, repeat, voluntary unpaid donors, QA system, rational blood product use, and lastly, the implementation of a quality system. We had some insight into that with Claire's presentation about quality systems, and I will cover that a little bit further. The WHO Africa Regional Office further defined the way forward as looking at policy and program development, I don't think that would surprise anyone here. We've heard plenty about the importance of developing clinical practice guidelines and policy, the importance of infrastructure development, an information management system so we can collect data about transfusion, strengthening blood donor programs, testing and assuring 100% testing for infectious diseases, quality systems, training, blood utilization, monitoring, and evaluation. But going back to the quality systems, I think that it's important that we take a moment to understand exactly what it is that the WHO is talking about there. Specifically, they're talking about developing guidelines and risk assessment tools. They're talking about working across the continuum of care between hospitals and blood and transfusion services to provide guidelines, tools, and technical support, and to create a global hemovigilance system that provides a mechanism for surveillance and alerts. Further, the WHO in an aide-memoire identified that there are some pieces of advice in order to fulfill these, the way forward. First, they advanced the idea of a national quality manager with responsibility for quality systems at all levels. They talked about development of a quality section within the blood center and each hospital blood bank. They recommended the provision of training for all blood center staff and other healthcare professionals, and the assessment of ongoing quality systems continuously. Again, you see quality over and over, and I've certainly heard it come up again and again. But what does that mean? How do we do that? And what about the clinical setting and the interface between the blood and transfusion center? We've appreciated again and again the importance that the two must be balanced and working together. So my question to you is this: who is a quality champion? What does a quality champion look like? In my view, this individual or individuals, because this job is far too great, I think, for any one person, this individual or set of individuals should look beyond immediate responsibilities to across the continuum of care and utilize a systems approach to quality that promotes the definition of roles and responsibilities, actually evaluates how reliable is our system, and are we implementing measures that support safety from arm to arm. This individual or individuals ultimately support the continuum of care by driving forward a quality culture that's focused on improvement and secures resources or advocates for resources to be directed to these activities. So I look out in the audience and I have the benefit of coming last in terms of I've heard so many of you speak adamantly about the importance of these factors. So I ask you, are you a quality champion? What role do you have in assuring quality from arm to arm? I want to reflect for a moment on a few structures that Claire brought forward in terms of strategy and synergy. She mentioned some work from Avitas Donabedian, who was looking at systems, process, and outcomes. And my recommendation is that we consider how quality builds from the inside to the outside and from the outside in. In the center, we have strategic goals, but strategic goals cannot be realized without the importance of the engagement of our people, our processes, helping people understand the value in what it is we're trying to do, and we must involve our customer. And each of us does have a customer in terms of the patient or the healthcare system at large, the provider or prescriber. And all of these things are fed by aspects of culture. What is our quality culture? What are the behaviors that we evidence as leaders in the field? What responsibility do we have as an institution or company? And how do we act on the information that comes from the quality system for purposes of innovation? I submit that our strategic goals, broadly speaking, should address questions of cost effectiveness, because although we are all short on resources at some level, I liked what was said that we must work within the resources we have, and prioritization, often informed by cost effectiveness and improved utilization, will help guide what should we be doing with the resources that we have so that we can experience better patient outcomes. These are some principles that I gathered from the ISO 9000 standards, which are typically applied within countries or companies that make products, although many healthcare services have also sought ISO accreditation. One of the foremost principles is that quality cannot be assessed by inspection alone. In other words, I cannot look at a blood unit and know simply by looking at it, even though I might inspect it under a microscope, I might evaluate color, I might look at the integrity of the seals in the bag, but I cannot know whether that blood was adequately tested. I cannot know whether or not the cold chain was intact throughout the entirety of its storage. So I must have trust in the system and assure that there are methods other than inspecting the blood unit itself to assure quality. I know that we oftentimes, when we come together as experts in the field, we tend to focus on our discipline. Quality, however, is customer focused. You'll notice in the prior diagram how I had patient outcomes as one of the goals, because the patient indeed is our ultimate customer. I also want to point out the role of us, leaders in the field, to establish a uniformity of purpose and create an environment where people can perform. We spoke earlier about potentially the fear that someone might experience if they notice something wrong, and the concern that if they report it, that they might either experience adverse consequence themselves, or they might invoke adverse consequence for a colleague. I think it's very important for us to reflect on what kind of culture that we are setting up in our institutions so that we assure that this reporting can be something that is without fault and not a situation where opportunities for improvement are passed by because people are afraid. Because people are indeed what drives results in healthcare. Everything we do happens through people. We also know that resources and activities need to be managed to reach our desired outcomes, and that, as we discussed earlier, our processes are interrelated. We cannot isolate one activity and experience improve that activity without considering what is the impact on the whole. I like what I was hearing in the conference about the mutually beneficial relationships that can be realized between blood supplier and hospital service, and the role of the different disciplines, including nurses, laboratorians, and physicians, in how the benefit is realized by our patients. Lastly, as was discussed by Claire, continuous improvement is imperative. So what does it look like to build a quality culture? I recommend that we consider the dimensions of awareness and knowledge so that we can increase certainty, expose, and explore. So we have a simple 2x2 diagram here where awareness increases on this axis and knowledge increases on this axis. If somebody isn't aware and they don't have knowledge, then they are ignorant. In other words, they don't know what they don't know. They're blind. If someone has great awareness but little knowledge, this might be an area of caution. I don't know, or I know what I don't know. In other words, I know that I don't know how to do that. And then there's amnesia, where someone has the knowledge, but they're not aware of what they do. In other words, they've gone through training, but they might lack feedback mechanisms or ongoing mechanisms to increase their awareness of how the quality system is performing. This is the quadrant that we want to occupy. And in fact, I suggest that we try to enlarge this quadrant so that we can exploit knowing what we know. In other words, not only having the confidence, the knowledge of what is the right thing to do, but increasing awareness about, is that working? What is the feedback from our system? At the Puget Sound Blood Center, I wanted to share with you what our house of quality looks like. I was reflecting on this later, and although it may not appear so to you, I was thinking, in some ways it can look almost like a hut, rather round, with a roof, although it's not a peaked roof. But at the base of our house of quality is knowledge and training, just as we discussed in the last slide, the importance of people knowing what they know. And then process control. Are we performing in the way that we intend to, that will give us the best outcomes? We also must manage equipment, supplies, our people. We need to document everything that we do, assess our quality ongoing, and create an environment of care where there is feedback about our overall systems, facility, and infection control. Whereas process control and knowledge are at the base, leadership and focus on the customer is at the top. This holds the house together just as much as this does, and continuous improvement moves throughout. Claire mentioned the Plan, Do, Check, Act cycle, and we have talked about the importance of having strategic planning and engagement of customers, financial performance, and ongoing learning and growth. This is how we evaluate within our organization whether or not we are performing according to our focus on quality. And I wanted to point out that in the center is vision, values, and strategy. So we are not only doing this to meet regulatory requirements because the government says that we must, but we actually look at how well this represents our values as an organization, which includes achieving excellence, seizing opportunity, thinking critically, demonstrating respect, and acting with integrity. This is my view of what quality arm-to-arm looks like. Here in this circle, we have the quality blood process. All of these steps are high-level evaluation, high-level activities that occur within the National Blood Transfusion Service in order to make sure that the blood is safe. But we've also spoken about the opportunities to improve the quality care process and making sure that delivery of a quality blood product is indeed a benefit to the patient, because safe blood transfusion occurs right in the center here. So my understanding is that we have talked about the importance of a quality system that wraps around this entire process. And I heard Dr. Dorothy talking about a view of a national transfusion committee, perhaps helping to drive forward some of the principles that assure that these different dimensions are working well together. I think from a regulatory perspective, I'll speak for in my country, oftentimes the focus is only here or only here. We need to look at the whole. Within the quality blood process, I also want to bring forward the importance of community sensitization so that we can collect the number of donors that we need to collect. We heard yesterday about the importance of civic engagement involving leaders, churches, mosques, other interested individuals, so that when we come forward and ask for their blood donations, that they're prepared to act. In terms of donor scheduling and mobilization, we also heard about developing a donor base, a collection of donors that are committed to the cause of blood donation and that ideally we can access again and again so that we retain them for future donation, not only the donation that they are giving on that day. Donor identification, although we did not touch on it in detail, it's important that we have a means of identifying who is our donor and that there is a deferral registry for an individual who may not qualify for that donation or future donation, so that when there is screening and qualification, we can assure that we weed those individuals out. An important element that I often see, we did not discuss it in detail here, but in other developing countries, is the importance of post-donation counseling. And where does the donor go if he or she finds out that they that they're not suitable for blood donation because of an underlying condition, or they have a test result that might cause them to need to seek medical care? Blood collection is key, as in quality control of blood. I think it's interesting that quality control of blood components is a factor that we may want to consider further in terms of what is the efficacy of the blood component. We heard yesterday about how much blood is in a packed red blood cell unit, how many red cells are there. And I think that it may be an opportunity to consider how we go forward with standards in this area. I'd be interested, Dr. Dorothy, if you have some comments on that at the close. Testing for pathogens, of course, and I mentioned referral to care, component preparation. We talked about how platelets may not be as plentiful as we might like, and supply management is a key aspect within the quality system for helping drive what components are prepared. We, of course, have activities of lot release and labeling, and this must be informed also by proficiency testing and external quality assessment. And storage is informed by how well our cold chain works. Lastly, we have inventory management and distribution. I think that one of the suggestions that I might have in this area is what exactly are the service level agreements between the blood supplier and the hospital, the clinical care interface, to make sure that we are in agreement with what components might need to be delivered at what time and what frequency in order to meet patient needs within the clinical setting. However, we also have a quality care process that needs to be considered. We discussed that there is clinical assessment, but a need for establishment of clinical practice guidelines. We talked about indications for consent and transfusion and how they may need to be informed by additional data within the sub-Saharan Africa setting, and the importance of multidisciplinary review of those practice guidelines. Patient identification also came up. We heard about how important it is to know where the sample is coming from for pre-transfusion testing, and that the specimen needs to be collected from the right patient We heard about the importance of the screen, not only typing, and of course, compatibility testing. All of these are areas, and I know that this came up regarding the work of the laboratorian. We need to have competency and proficiency in these areas, such that when a blood is ordered, we know that it is being properly utilized, that the right component is selected, again, helping inform our service level agreements, and that when blood is administered, that nursing is monitoring on an ongoing, as part of the transfusion and post-transfusion, for adverse events. Adverse events are reported, managed, and that we have an ongoing system of hemovigilance. So again, the intersection is important in terms of assuring safe blood transfusion. But again, reflecting on the words of Dr. Deming, optimization of a single part of this very complex chain of events can result in sub-optimization of the system as a whole. In other words, if we over-transfuse, that harms the supply of blood. If we also have overly restrictive criteria for donor collection, that may harm the overall supply as well. So it's important that we evaluate this on a complete scale. Next, I wanted to talk about risk reduction, what is ultimately, in my view, the purpose of quality, and that is to reduce transfusion-transmitted infections, as well as non-infectious risk, and assuring an adequate supply of blood. The risk of transfusion-transmitted infections varies from high-income countries to low-income countries in such a way that high-income countries experience less risk of detecting transfusion-transmissible infections for HIV and hepatitis as compared to low-income countries. And this, again, is from the WHO database from the year 2012. We also know that the frequency of blood donation varies across the world, with certain countries, specifically in sub-Saharan Africa, experiencing fewer than 5 donations per 1,000 population. And this is different from many of the higher income countries in North America, Europe, and Australia. We also respect that it's not only a matter of how voluntary non-remunerated blood donation, but it's repeat blood donation. So here I have highlighted for HBsAg, HIV, hepatitis C, the repeat voluntary non-remunerated blood donor review of multiple studies have the lowest rates of prevalence or reactivity for infectious disease markers. So retention is indeed important. Looking at non-infectious risks, in the study, the serious hazards of transfusion, otherwise known as SHOT, there was an evaluation of how often what are the hazards of transfusion? And I'm not only talking about adverse events, but rather errors, mistakes, or near misses. What we see is that incorrect blood transfusion or incorrect blood components being transfused is a primary risk for hazard of blood transfusion, far greater than some of the other risks such as transfusion-transmitted infection, trolley, etc. And this is for the time period 1996 through 2004, so many different years. As you can see, the numbers are climbing year over year in this study that was published in 2006. Why do you think that is? Are we getting worse? No. We're actually creating a better feedback mechanism and actually getting better reporting of the near misses that are occurring in the transfusion setting. So what are those mistakes? What are those risks? in the medical event reporting system on transfusion medicine that was a study conducted, or this was published by Kaplan, and this was performed in Canada. There was an evaluation of what types, in a no-fault reporting system, how many events constituted harm, how many events were reported that were near misses or actually reached the patient but did not cause harm, and how many were interdicted before it got to the patient. As you can see, the vast majority, when you institute a voluntary reporting system, the vast majority can be detected early before it reaches the patient. Why is that important? Reporting of near misses constitutes a mechanism for decreasing the potential for harm, so that as we evaluate what's happening beneath the water, think of it as an iceberg, we might see harm, but what's happening down below the waterline that we can act on before it reaches the patient. And the evaluation is that if you can implement systems down here, you prevent harm from reaching the patient. So where does transfusion error occur? This is a separate report on that similar data set from that same study, or from that same data set from MERS transfusion medicine, where there was an evaluation of where do events occur. I want to be clear here, although the job description as entitled in this column here, this isn't by no means meant to say that nurses are less reliable than physicians, for example. Rather, it's to point out that these events are happening at the bedside, either at the point of sampling of the samples mislabeled or the wrong patient collected, or incorrect blood product ordered, patient given the wrong product, or there's a mistransfusion event. So to the extent that a nurse may not perform these specific activities within the context here, these, I suggest, are still the areas where error may be occurring. And I think that we heard some opportunities for that based upon Professor Hume's review of her data. So we also heard about the importance of blood transfusion related to maternal care, and that hemorrhage during labor, delivery, and the postpartum period, thank you for the excellent presentation in this area, accounts for the 1/3 of obstetric death around the world, and it's the leading cause of maternal death in Africa. And that half of the maternal deaths from severe bleeding in the world occur in sub-Saharan Africa, with 65% of these deaths occurring during the postpartum period. In a review by Bates, there was an evaluation of why is there ineffectiveness of blood reaching these patients. And the finding was that at least 25% of all maternal deaths in sub-Saharan Africa could be prevented through rapid access to blood transfusion. Further, there was an evaluation of why is blood not available, and these were the reasons given: inability of the women to pay in advance, lack of blood donors, unwillingness of relatives to donate blood, and lack of supplies for the blood bank, storage facility, or transport. But lastly, I wanted to point out there was some data that was released in 2014 that was from southwest of Kenya, where maternal death is linked to high neonatal mortality, and that in this evaluation of 59 maternal deaths in the study, only 15 babies survived the first 60 days of life. So I think to the extent that the mother dies, there is an association with the baby also passing, and the impact on the rest of the family that comes with the loss of the mother and the children being pulled from school to care for their other siblings. So this is not only a matter of concern for the mother, but the family as a whole. So in short, efficacy relates to donor selection, validation of our processes, equipment calibration, quality control of blood components. And lastly, I wanted to point out another picture from a different setting. In this case, a mother whose daughter has just given birth in the hospital is being given a unit of FFP that she's going to carry to the bedside for transfusion. If any of you have worked with a frozen unit of FFP, do you think it made it to the bedside? This is exactly what we need to consider in terms of, I'm certain that this blood bank worked very hard to produce a high quality blood component, but to the extent that it's not available or efficacious for the patient, it is really not meeting the patient need. So continuous improvement. I suggest that we really evaluate in the sub-Saharan African setting what is normal versus what is unexpected. Written methods, procedures, and instructions will help with that. Looking at what the expectations are, who's authorizing those procedures and approving them. Do we have SOPs, nursing protocols, clinical practice guidelines, order sets? How do you identify whether you're meeting the expected outcomes? Do you have data that has been collected? Is it analyzed? Where should it be analyzed? And how to assess those results? In going back to reflect on my institution, we've implemented a measure of what we consider whisper metrics, where we look at waste, impact, safety, performance, and risk. That way, we are not only looking at adhering to are we efficient or are we safe, but are we keeping our commitments to our customers? Are we reducing risk and hazard? And are we reducing waste? I think an example of this, though it's not ours alone, comes from an evaluation of positive bacterial infection through apheresis platelets. This is FDA data, Food and Drug Administration in the US from fiscal year 2001 through 2012. As you can see, there's been a decline in confirmed positive units such that one might ask, well, why did this happen? And it wasn't regulatory pressure per se. It was people like you that came together and recognized that bacterial testing was something that where we could interdict a unit that from reaching a patient that was contaminated with bacteria. So between 2002 and 2003, there was testing that was implemented voluntarily through standard setting organizations that looked at the cultured units from the point of preparation throughout the shelf life of the unit, or there was a method of detecting bacteria at the point of release. And as you can see, that has had an impact within the US setting. My point on this is that a group of experts like yourselves can come together, develop consensus guidelines or standards, and actually have a bearing on the safety of blood transfusion without it necessarily being a regulation. I won't cover this in detail, but the Plan, Do, Check, Act cycle is one of the means by which we can assure that evidence-based practices, and I'm talking about evidence within our setting, within your own facility, are implemented. Do you review your data, review package inserts, conduct validation, verification, and collect observational or prospective data? I also want to point out the importance of checklists. We heard this earlier when we were talking about why incomplete information might be collected or when a blood component is administered. And checklists can be, or forms, documents can be very useful tools to cue people to remember to collect the correct information, albeit they need to be simple, straightforward, and emphasize points of importance. And we also talked about the importance of multidisciplinary collaboration. I suggest that blood utilization and transfusion committees are exactly that, particularly if they include multiple dimensions of your facility, including surgery, oncology, OBGYN, nursing, laboratory, perhaps a member of administration, particularly if you're going to be going to administration and saying, we need more money for this, and ongoing metric reviews. Ideally, I really like the idea that was brought forward about cross-institutional quality meetings between the hospital, blood bank, and blood supplier. For process excellence is something that is continuous. We, in our institution, have just begun to really actively pursue Lean Six Sigma, which is a mechanism for driving down variability in your process and organization. It starts with 5 very simple things: sorting, standardizing, simplifying, shining, and sustaining. And I encourage that as you gain more experience with the Plan, Do, Check, Act cycle, that you begin to define, measure, analyze, improve, and control so that you can sustain and hold the ground that you gain through your process improvement efforts. This, of course, will again be led by people that are here in this room to deploy resources, align your teams with the vision, and reduce waste. Lastly, I want to point out that high impact leadership is challenging. This is from a white paper published by the Institute of Healthcare Improvement, where they were defining what types of behaviors characterize a high impact leader that carries people through the thick and thin and helps them to address very real problems. I thought it was quite important to point out that this person must be consistently focused on people, patients, staff, donors, family, and call forward the importance of perspective of people on a regular basis. This individual should also be person-centered, engaged in the front line, accessible to people who work with the patient. What about the nurse at the bedside? What about the lab tech who is working third shift? What about the residents? As a champion, are you authentically visible as a champion for improvement? Or perhaps are you the one that is always saying no? I think a quality champion and a high impact leader is relentlessly focused on vision and strategy, is transparent about what it is that needs to be achieved, and how the system and the organization is performing, both good and bad, so that defects are brought forward and progress is illustrated. And last, I think it's important that a high impact leader encourage best practices, and not only within your primary discipline, but across boundaries. So I'm asking you to imagine, what's it like to have as many donors as you need, and to always have the beds full, to not have to struggle to meet the demand? Think about it. To have all the blood processed in exactly the right configuration so that you produce the right components at the right time, that all the blood is 100% tested, that it's available on the shelf exactly when you need it. What's that feel like to the patient in need? Maybe you are already there. I know in my institution, this is a daily challenge that we need to constantly rally ourselves to address the deficiencies that we may experience. But it's within reach, and we must always keep this at the forefront of our thinking. To reflect on Donna Bedian's words, systems awareness and systems design are important for health professionals, but they are not enough. They are enabling mechanisms only. It is the ethical dimension of individuals that is essential to a system's success. Ultimately, the secret of quality is love.